I'm going to talk about breastfeeding and some of the things that sort of the concerns that have kind of gone through the breastfeeding medicine listservs, and talk about really ways, I guess, focusing on ways that we can optimize breastfeeding during these times when the safety net is kind of at risk. So I need to move some stuff over here. First I want to just talk about breastfeeding in general, talk about risks of not breastfeeding, just to remind us like why we want to make sure that babies and moms are breastfeeding. And we'll talk about some really cool components that may play a role in improving the outcome of children with COVID-19, although we really don't have any great evidence yet on that. We'll talk about some key postpartum strategies that we currently have been using that you all have been accustomed to working at St. Mary's and Meriter regarding optimizing breastfeeding success before discharge. And then we'll talk about current recommendations from the CDC, the AAP, and the World Health Organization, and talk about how those are similar but yet very different. And then how these changes with COVID have affected those key postpartum strategies, putting moms and babies at risk for not breastfeeding successfully, and the things that we can do to really help them when you're taking care of them in the hospital, when you're seeing them, especially during that first week. So I want to share this graphic with you. This actually came from the United States Breastfeeding Committee, and it basically just is a visual way of seeing all the different aspects of life that have been affected for families who are dealing with this COVID crisis while they're having children. So they're doing like voices from the field, you know, taking stories from different people about how they're affected. And so families have expressed fear and uncertainty. They've expressed a lot of stress, of course, which I think many of us are hearing when we talk to our patients on telemedicine. There are the Native Americans who have their own experiences, which are somewhat different, with high rates of COVID-19 illness. There's the idea of valuing protection of their families, yet balancing that with just not being able to have very many people coming over to help them. There's the separation issue after childbirth, which we're going to talk about more. There's some optimism, hospital visitor policies, changes, etc. So there are a lot of dimensions to this whole issue, and we'll be talking about just some of those dimensions today. So first, I want to talk about just why we breastfeed, why we recommend it. And so the research on breastfeeding, on the differences in health between children who are breastfed and those who are not breastfed has become pretty robust. And the differences that we see are not just based on one or two studies, but based on systematic reviews and meta-analyses to really make sure that we're not conflicting our observations with other confounding variables such as wealth and age and education, things like that. So we know from research, we feel pretty secure that infants who are not breastfed have higher rates of necrotizing enterocolitis, particularly, of course, among premature infants, and sudden infant death syndrome. So that's one of the main ways that children who are not, where we can attribute death from lack of breastfeeding is through sudden infant death syndrome. We know that babies who are not breastfed have higher rates of gastrointestinal illness, severe respiratory infections. So, you know, babies who breastfeed get colds too, but they just don't become as ill. We definitely see more otitis media among infants who are formula fed. Babies who are formula fed also have higher rates of obesity, type 1 and type 2 diabetes as they are older. There are higher IQ points among children who are breastfed, and largely this is well documented actually with probably can be attributed to these certain components of breast milk, particularly components that are generated by the difference in the gut mucosa, but in addition, the fatty acid difference in breast milk as well. And then malignancy, children who are not breastfed have higher risks of leukemia and lymphoma. And we know part of the way that we know that these benefits exist is that the more breastfeeding that happens, the higher the protection from these diseases. So we know that dose is important, that the more that an infant is breastfed, the lower these risks. But for mothers too, breastfeeding is really important. So we know that women who do not breastfeed have a higher risk of postpartum bleeding, particularly in other countries. Here we have all these great meds to deal with postpartum bleeding, but in other countries where these meds are not available, where women are giving birth in with much lower resource, in a much lower resource environment, they have slower uterine involution. There's decreased child spacing because women ovulate sooner if they don't breastfeed. And the big thing I think we're identifying is this whole issue of insulin resistance, that women who do not nurse do not resolve that pregnancy-related insulin resistance as quickly or as fully as women who breastfeed. So they have higher abdominal visceral fat. And we think that this is sort of the link to these findings that we're seeing in multiple studies from many countries, that women who don't breastfeed have higher rates of type 2 diabetes, hypertension, heart disease, and stroke. And again, that may all go back to the higher risk of metabolic syndrome because they didn't breastfead. In addition, some of these breast cancers are also related to higher body fat, including ovarian cancer, breast cancer, and endometrial cancer, which is actually premenopausal endometrial cancer. And then we know that there's a financial impact of breastfeeding. So there's this really cool calculator at the United States Breastfeeding Committee website that has the link down below. And so I played with this calculator recently, and based on 2014 data, I switched the rates of breastfeeding on top, like I switched it from 82.5% initiation, 69.7% exclusive, et cetera, across the top. I switched it all to 80%. And by switching, like making sure that everyone's breastfeeding until 6 months exclusively to 80%, and at 12 months to 80%, we actually can save like $1.7 billion in medical costs and $835 million in non-medical costs, and this is just in the US. Death costs of $6.9 billion, and then we can save 1,500 maternal deaths and 300 child deaths. So it does have a definite impact on our society as well. So it's interesting when I read the World Health Organization recommendations, the Academy of Breastfeeding Medicine recommendations on breastfeeding, there are several comments about how babies who experience COVID-19, who become ill with COVID-19, are probably going to be better off if they're breastfed, based on the immunologic factors that are in breast milk. So there's not only passive factors, but there's also active. There's passive factors like IgA particularly, but there's active factors that actually help to mature the infant's immune system. So let's take an example. So again, we don't have any great numbers regarding infants who die from COVID-19, whether or not they're breastfed versus formula fed. But theoretically, we think that it can make a difference. So, for example, if we look at severe bacterial infections, we know that breastfeeding protects among premature infants late onset sepsis. And this was a study that was published in 2013, and they found that among these 175 babies who developed late onset sepsis, there was a 57% risk if they were formula fed and 7% risk if they were either given mother's own milk, which is the MOM, or at least partial mother's own milk. And so the odds of the late onset sepsis decreased by 19% for every 10 milliliter per kilogram per day dose of mother's own milk. And they also found that the NICU costs were lower in the preemies who received the highest average daily dose of human milk in the first 28 days of life. So that's just an example of how children who are breastfed actually have less severe disease. But let's talk a little bit about some of the mechanisms. So it's not just about antibodies. Many people say, oh, it's just antibodies, that may not make that much big of a difference, but it's so much more than that. So I just want to kind of walk through a few of these different aspects of breast milk that may make a difference. One is that we know that the gut flora is very different in babies who are breastfed versus formula fed, and there's lots and lots of literature on this now. So this was from a study in 2015. The gut microflora in preemies who receive breast milk have fewer pathogens. So we're not as likely to see E. coli, Klebsiella, Group B strep, and other pathogens that can translocate through the gut and cause sepsis and other infections like UTIs. In addition, breast milk has oligosaccharides, and oligosaccharides have become very important components, studied, many studies being done right now on human milk oligosaccharides. And in fact, now there are a couple oligosaccharides that are added to formula, at least for the last 5 years or so. Oligosaccharides are actually, they play multiple roles, but they're prebiotic in that they actually help to feed the healthier bacteria that we find in the infant gut. So the infant gut who's breastfed is more likely to have an abundance of bifidobacterium, and part of the reason for that is because the oligosaccharides feed the bifido. And the oligosaccharides in breast milk are much more robust and more likely to feed bifidobacteria than the few oligosaccharides that are added to formula. And then in addition, the mother's own milk, they have it has 250 plus probiotic species of lactobacillus. And so it's constantly populating the breastfed infant's gut as opposed to a formula-fed infant who doesn't have access to those lactobacilli in breast milk. So this is a graphic from one study showing that on the left, the protective mechanisms of breast milk components versus what happens if those mechanisms are not there. So these are just a few mechanisms that bodies use, that the infant gut uses in coordination with receiving breast milk. So we know that the maternal antibodies, particularly IgA, lines the columnar epithelium of the gut and help fight infection. We know that lactoferrin in breast milk will actually sequester iron away from bacteria that's in the gut to prevent those pathogenic bacteria from using iron in order to grow and proliferate and become stronger. And then oligosaccharides not only feed healthier bacteria, which competes with pathogenic bacteria, but the oligosaccharides also act as decoys. So the decoys actually, they mimic the epithelium of the gut. So the pathogens who are striving to attach to the gut and translocate through the goblet cell actually attaches to the oligosaccharide, and then the oligosaccharides are pooped out with the pathogens, and voila, goodbye pathogen. So it's actually a pretty beautiful system. And then, so you can see what they're trying to show on the left is that you have less translocation of the bacteria through the goblet cell and not heading towards the maternal lymph nodes. Whereas on the right-hand side on B, the little dots, the little red and purple dots, the bacteria are actually heading towards the maternal lymph nodes and then can get into other organ systems such as the spleen and liver and other places, increasing the risk of infection. In addition, we have this beautiful system called the enteromammary circulation system, where when mothers ingest bacteria, pathogens basically through their nose, through their mouth, these pathogens end up in the gut, and then antibodies are made to these pathogens in the gut, and those move through not only the lymphatic system, but the blood system into the breast. And within a couple of days of maternal illness, we'll see IgA antibodies to those viruses or bacteria. And then another really cool thing is that the breast actually responds directly to infant illness without the mother being ill. So you'll see pictures like this if you hang out in breastfeeding sites like I do. You'll see these really cool pictures that mothers will post showing differences in their breast milk. So this mother posted her picture of her milk. On the left was when her infant was sick, and on the right when her infant was not sick. And so what's happening there? Why does it look so rich or proteinaceous on the left? Well, this was a study that was done in 2012 looking at the changes in the immunomodulatory constituents when the nursing child was ill. So what they did is they actually took two samples, sample 1 and sample 2. Sample 1 was taken when the infant was ill, and sample 2 was taken when the infant no longer was ill. And this group of mothers were not ill themselves. And this is 20 mothers, so not a huge study. But you can see the difference in the first sample from the second sample in the number of CD45 cells per milliliter. You can see that they're much higher in the first sample than in the second. The same thing for the lymphocytes and the neutrophils and the macrophages. And on the right, you have the control infants, and you don't really see that huge of a difference between S1 and S2. So I just want to make a point about this, is that human milk cannot do this work if pumped and fed asynchronously. So if mom is sick and she's making those IgA antibodies to the illness that she and her infant are being exposed to, we definitely want the baby to have that fresh milk. Because if she's pumping that milk and then putting it in the freezer and then giving last month's milk, that last month's milk is not going to have the IgA antibodies to what she was just exposed to. In addition, stored milk doesn't really have the same amount of, it doesn't have the same bioactive activity as fresh milk does. So we definitely want moms to be feeding the baby the milk. We want it to be there in real time, basically. So breastfeeding, and if mom is pumping, to try to give fresh milk as much as possible. All right, so now I'm going to turn to getting off to a great start. So let's talk about some of the very important evidence-based ways that we help moms and babies breastfeed in the hospital, making sure that they're successful, so that when they're leaving, they're breastfeeding. If they don't start out breastfeeding when they leave the hospital, the likelihood of being successful is very low, and that's been shown in many studies, which is the main reason why both hospitals are baby-friendly certified. So the first thing that all of you have observed is that we put babies skin to skin after birth. And the American Academy of Pediatrics had a great review, it's actually the policy statement on the recommendations for skin to skin. So we know that putting babies skin to skin does help to stabilize the baby's in a cardiorespiratory manner. Babies tend to experience less pain when put skin to skin. They have improved growth. There's improved autonomic, GI, and neurobehavioral adaptation. They don't get as cold. They're not going to drop their blood sugar and their temperature if they're skin to skin with mom. Babies are not going to cry as much. And actually, for the mother, it does have an effect. Like her ability or the rapidity at which she starts to ramp up that love and affection for her infant increases with skin to skin. There's less postpartum hemorrhage. Studies have actually looked at depression scoring and cortisol levels in moms, and those have been decreased. There's more organized breastfeeding, which we'll talk about, and then increased breastfeeding exclusivity. And there's something to be said, we're going to talk about this, but there's something to be said about that early feeding that is driven up by having moms and babies skin to skin right off the bat. And of course, when babies are born, they are, they're not born asleep, right? You don't give birth and have the baby like, oh, wait, let's wake up the baby's sleeping. Like the baby's like, whoa, what just happened to me? I'm just on earth. And so that's the best time to get those babies to be breastfeeding, because they're going to crash, right? They're going to crash after this whole ordeal of being born. And that's not the best time for them to initiate breastfeeding. So rooming in. So I don't know if any of you have seen Mrs. Maisels, but I was so excited when I saw this on Mrs. Maisels when she came into the room and she shut the door when they put the baby back in the nursery. But this is what some of the rooms look like back then. Anyway, this comes from the statement from the AAP again in 2015, talking about the evidence for rooming in. And there is good evidence that having moms and babies staying together in the room does improve patient satisfaction. There's less risk of an infant being abducted and less risk of the infant being abandoned. Basically, it encourages bonding between mom and baby. Because babies tend to nurse more frequently when they're rooming in, we see less hyperbilirubinemia and increased likelihood of nursing up to 6 months. The other thing that many of you may have noticed, maybe not, maybe, depending on how long you've been around, is the delaying of the bath. So we used to bathe babies like pretty quickly, like they're dirty when they're coming out, let's just get them all cleaned up. But now we don't do that as much anymore, because there is evidence that babies actually breastfeed better and are more successful breastfeeding at the time of discharge if they haven't been bathed right away. And so this was probably the largest study done on delaying the bath, where they took 996 mother and newborn dyads, and 448 were pre-intervention. So these were babies who were bathed on average about 2 hours after birth. And then after the intervention of delaying the bath, 548 dyads, the babies were bathed about 18 hours after birth. And they found that the breastfeeding rates did increase. So the in-hospital breastfeeding rates increased from about 60 to 68%. And the exclusivity rate increased as well with an odds ratio of 1.49. So there was definitely a trend towards delaying the bath of increasing breastfeeding rates. We don't really know why, but the supposition is that by waiting to bathe, the babies they don't get as cold. They don't have just a subtle degree of hypothermia. Hypothermia is never good for infant feeding because they really just sort of clamp down, they hunker down and don't really, they just don't feed well, they're not strong enough, and they're tired. And so by reducing the risk of hypothermia, we can improve breastfeeding. The other issue, and these are the baby-friendly hospital initiative steps. So many of you may have seen these. And again, Meritor, and I believe St. Mary's now is baby-friendly. Meritor has been certified baby-friendly since, I think, 2007. And so these are the steps that are vital or essential to be certified baby-friendly. We've been recertified again at Meritor. But I want to point out specifically the immediate and uninterrupted skin-to-skin contact, which we talked about, and then initiating breastfeeding as soon as possible after birth. And so I want to talk about that as soon as possible after birth feeding, where I mentioned that babies are so awake and alert. But what we're finding in more recent research is that expressing that milk early, even if it's not having the baby to the breast right away, but even hand expression early, getting a pump on that breast early within the first hour can really make a difference in that volume that mom is going to be able to achieve over time. So if you look at this study, you can see, I don't know if you can see my arrow or not, if I have an arrow tool here. What did I do actually? There we go. Okay, so if you look at like days, if you look at these days here, I'm not very good at drawing this. Okay, never mind. So anyway, if you look at the days between, days 1 and 5, you can see that if moms are expressing within the first hour, you can see that their volumes by day 5 are much higher than the volumes that are achieved if moms start to express after 1 hour, but before 6 hours or after 6 hours. So there's something about that really early expression, and this was done among mothers of very low birth weight infants who obviously their babies are in the NICU. And if you look at their rate of lactating at 6 weeks, you can see that if they expressed within the first hour, they were much more likely to be breastfeeding at 6 weeks as opposed to those who started after 6 hours. And we know that there was a recent, very large systematic review that looked at reasons for early weaning, and there's two. The biggest reasons are chronic pain and low milk supply. Get rid of that tool here. There you go. Okay, so let's talk about what happens now with the COVID situation. So this is just a parking lot issue. I just want to mention that there was a study done in Upper Manhattan, Bronx, looking at the rate of asymptomatic SARS-CoV-2 positive mothers who entered. So this was a group, this was, of course, this area of New York was hardest hit early on with COVID-19. And this was done up in the Washington Heights, Bronx region in the Columbia Presbyterian Hospital System. And they early on, around in like late March, and they started testing every single mother who came into labor and delivery, which is what we're doing now. And they found that 13.5% were asymptomatic positive, and then 1.9% were symptomatic and were positive. And so this was before, of course, when we started testing, and I had spoken to some of the physicians there, and we were just amazed at how prevalent the asymptomatic rate was, and we'll come back to that. So the World Health Organization at this point, they really haven't changed their stance. They state that relatively few infants have been confirmed COVID-19 positive, and those who have been reported in general have had mild illnesses. And certainly some babies have died and some babies have become very ill, but in general, it has not hit the newborn population as much. Diet should be enabled to remain together, practice skin-to-skin contact and rooming in, especially immediately after birth during establishment of breastfeeding, whether they or their infants have suspected or confirmed COVID-19. And when complications prevent a mother from caring for her infant or continuing to directly breastfeed, she should be encouraged to express her breast milk and safely provide that breast milk to her infant. So this is their infographic from the World Health Organization to practice respiratory hygiene, wear a mask, wash hands before and after touching the baby, and then routinely clean and disinfect surfaces. So the American Academy of Pediatrics put out their initial guidance, and actually I should say that as I am talking right now, the AAP is talking right now from the authors of their recommendations. So there's a webinar, you may be able to find that later, find a recording of it. Their initial guidance came out on April 2nd, 2020. And there was a fair amount of disappointment, I'll be honest with you. I know many people who are on the AAP section on breastfeeding, and they felt that their stance was different than the recommendations that came out from the AAP. They very much indicated that direct breastfeeding was discouraged and recommended pumping and bottle feeding of expressed breast milk by a non-infected caregiver. And that the likely benefits, so this is what's interesting to many of us, is that the likely benefits of temporary maternal and newborn separation at birth for decreasing the risk of newborn infection should be discussed with the mother, ideally before delivery. So they're saying, okay, we need to discuss the risks of newborn infection. But then they went on to say that published data on newborn health outcomes after birth to mothers with COVID-19 universally describe separation at birth, and in many cases for prolonged periods of time. So that was the information that came out of China. Therefore, the risks of postnatal infection in the immediate newborn period consequent to usual mother-infant care cannot be adequately assessed. So there's really no way to assess, based on this statement at this time, what really the risk is, but yet, oh, there's a risk, so then separate. So they also acknowledge that it may not be applicable to every clinical environment. We know that at that time, particularly in New York, there was no place to separate moms and babies. And so there may be a need for different decision-making based on the availability of PPE and separate rooms for moms and babies. They went on to say that if the mother chooses to room in, or if there's not the capability of caring for an infant in a separate area, the infant should remain at least 6 feet from the mother at all times with breast milk feeding, meaning implying that still don't directly breastfeed, but pump and bottle feed. And if the mother also requests skin-to-skin contact and direct breastfeeding, she should comply with strict preventive cautions, including use of masks and meticulous breast and hand hygiene. However, no one has ever really defined what breast hygiene is. They also recommended changing the routine to the bath and to bathe the baby right away. And that does make some sense based on the study that I'll show you, that there is a risk of there being COVID-19 particles like, the RNA evidence within the first several hours postpartum. So it does make sense, although again, we do have that risk of the baby not nursing as well if they're bathed early. The AAP updated their information on May 20th and stated that delayed cord clamping should continue. There's no evidence of transplacental viral transmission from the mother to the infant, and that the mother can put the baby skin to skin, basically holding her infant during the delayed cord clamping if she has a mask on. And again, this is for mothers who are COVID positive or PUIs. And then they went on to say that rooming in is still a controversial question. Most newborns with COVID-19 do well, but some infants can get very ill, and the risk to the infant is not known. And the safest course of action is to decrease the risk of infant infection the safest course of action is to separate, which we'll talk about that because we'll talk about that support person. And then they did acknowledge that separation of mother and infant does have downsides. And if after discussion with the clinical care team, the mother chooses to room in, the mother should again stay a distance of 6 feet apart and try to pump and bottle feed, again, still that emphasis. And they'd also said that they did emphasize more this time. This was something that they were criticized about, not emphasizing the importance of breastfeeding. They did emphasize that breastfeeding and breast milk feeding is important for infants, and that there's no advantage to early discharge for newborn or families. And that's something that we have seen a change in our community where we're not doing early discharges anymore. The Center for Disease Control has been a little bit more of a pendulum. So their initial guidance was to separate the infant away from the COVID-positive mother and to put them in separate locations, have the mother pump and provide breast milk, and have her use caution when pumping, using a mat, cleaning her hands, cleaning her pump, wearing a mask. And then they have said in their initial guidance, but if mom decides to co-locate with the infant, then the infant should be kept 6 feet away. Mom wears a mask to breastfeed, use an isolette rather than open crib. And then they mentioned breast milk feeding protects, oh no, I'm sorry, their update. So their update in mid-April sort of softened that whole thing. And this was in response to a fair amount of criticism, because they did say that if mom decides to co-locate, and they didn't put in there, well, let's have shared decision-making. So then this time in mid-April, they said, well, families along with healthcare providers should decide whether and how to start or continue breastfeeding, including whether to co-locate. So that was on the top of the recommendation at that point. So we all cheered. We're like, yes, this is important. You know, we need to make sure that families are sharing the decision-making on what's going to happen. And then they went on to say, if you are COVID positive and choose to directly breastfeed, wear a face mask, wash your hands before feeding, and there's no evidence to recommend washing the breast before feeding, which I thought was interesting. And if you are COVID positive and choose to express milk to establish and maintain your milk supply. A dedicated breast milk pump should be provided. Wash your hands, wash the pump parts, etc. And then, if possible, have someone who is well feed the expressed breast milk to the infant. So then they updated on May 20th. And they had stronger language, and they said that it is important to temporarily separate the newborn from the mother, and ideally in separate rooms, or if they are going to be in the same room more than 6 feet away, and the infant in an isolette. So, you know, many of us are scratching our heads thinking like, okay, who's talking to who, and how come we're not part of that conversation? So I would say I didn't bring in the Academy of Breastfeeding Medicine's recommendations. The Academy of Breastfeeding Medicine is an organization that is made up of physicians who are dedicated to the protection, support, and promotion of breastfeeding around the world. And our statement pretty much aligns more with the World Health Organization. So in the meantime, this really interesting study came out from the UK, and this was the United Kingdom's obstetric surveillance system. They did this study looking at SARS-CoV-2 infection in pregnancy. So what they looked at 427 pregnant women who were hospitalized for SARS-CoV-2 infection between March 1st and April 14th. So they found that this was about 4.9 of 1,000 pregnant women. And they compared what happened to them to 694 women who gave birth between November 1st of 2017 and October 31st, 2018. These women were not just hospitalized for labor and delivery, but they were hospitalized because they were sick with COVID-19. 81% of these women were symptomatic in their third trimester, and on average, they were about 34 weeks gestation. 1 out of 10 needed respiratory support, and about 5 died. So 1.2% of these 427 women died. 243 out of the 427 women at the time that they published this had given birth. 74% at term, 12% at preterm due to maternal respiratory compromise, and 20% of the cesareans were intubated due to respiratory symptoms versus 7% of those who they compared with who gave birth in 2017 to 2018. All of them, everyone did routine skin-to-skin and followed the World Health Organization guidelines. The women wore masks when breastfeeding. So they directly breastfed, they did not separate them, there was skin-to-skin, etc. They found that 5% of the infants were SARS-CoV-2 positive. So interestingly, 6 were positive in the first 12 hours. And that's why I mentioned that it makes sense for babies to be bathed right away, because for them to be positive within 12 hours, this is probably, like we're thinking, this may be coming from the stool or other maternal secretions that ended up on the baby. 2 were via vaginal birth and 4 via cesarean, so I thought that was interesting. Infants who were over 12 hours, who were positive after 12 hours of age, 4 were elective cesareans and 2 were vaginal births. But again, it's an overall really small amount of infants who were positive. There's not really any data on the illness of these infants. They know that 1 of those who were tested and were positive in the first 12 hours went to the NICU, and 5 of those, 5 of the 6 who were positive after 12 hours went to the NICU, but they didn't go to the NICU necessarily because of COVID-19 related illnesses. They just don't have any information on what happened to the infant. So I just want to mention about support partners. So we know that support partners are really important, right? You know, everyone needs a support person when you're giving birth in the hospital. And oftentimes that support person happens to be the parent. And that parent was exposed to their partner who was giving birth, right? We are doing routine screening in general for people entering medical facilities like the hospital or offices. So checking for symptoms, checking the temperature. But right now there are no routine recommendations to screen those who are those support people. So we're not routinely doing, testing. We're not routinely testing them for COVID-19. So we have no idea if that person is coming in to care for the baby, if mom and baby are separated in the room. We have no idea if that person who is actually there to support the baby, if that person is an asymptomatic carrier anyway. So this all reminds me of what happened when we had H1N1 infection, where we explained to the CDC, you know, if they had originally recommended as well for H1N1 that we separate mom and baby if mom comes in and she has influenza symptoms. And many of us argued, well, look, you know, that doesn't make sense because influenza is so infectious that how do we know the person who's caring for that baby is not, you know, pre-symptomatic? And so the infant has a higher risk being cared for by someone who may give them the infection anyway, and then they don't have the protection of breast milk. So I think that underlies the argument by the World Health Organization, and many of us also feel that way. And again, looking back at that parking lot slide about the asymptomatic rate of people coming into the hospital who are in labor, we can imagine that we have a fairly high rate of asymptomatic positive testing among those who are not coming in labor. I want to talk about a little bit about health inequity for a moment. So I wanted to show you the rates of breastfeeding in our country at 6 months by race and ethnicity. So if you look at this is, again, at 6 months, our latest data from 2016. You can see that African Americans and non-Hispanic Blacks in the second line and the Hawaiian Pacific Islanders have the lowest rates of breastfeeding at 6 months. We also know that poverty plays a very important role in breastfeeding rates, and that the higher the poverty level, the less breastfeeding that there is. So one interesting outcome from that UK study was that being Black or of minority ethnicity was strongly associated with admission for SARS-CoV-2 infection, which I know all of you have probably heard about in the news and in stats that you've seen, that people of color, African Americans, Latinos, for various reasons, have higher risk of COVID-19. And in this particular study, they found that the effect persisted when controlled for comorbidities such as age, body mass index, and whether or not they lived urban or rurally. So I guess my concern here is that we know that African Americans and people of color have a higher risk of lower breastfeeding rates. And then if we separate them, this is actually just going to increase their risk of lower breastfeeding rates, which increases their risk of infant death, infant morbidity and mortality, as well as negative outcomes over the years from mothers. So I want to mention that the dyads, when they do deliver at hospital, when they do enter hospitals for delivery, they're going to have different experiences depending on where they live. And part of that is really the interpretation of these varying recommendations, because some hospitals are going to perhaps look at the recommendations from the CDC in mid-April and really emphasize shared decision-making, which is what my understanding is what we're doing at Meritor. Whereas I have friends in other parts of the country who are really battling physicians who are making decisions to strictly separate and not allow shared decision making, which is really more the AAP's recommendation. So again, different hospitals are taking different approaches. The lack of routine testing increases the separation for mothers who are people under investigation, and possibly unnecessarily. So routine testing is really important for families so we can avoid unnecessary separation. And then African American women and those of racial ethnic minorities will experience less shared decision making in healthcare because we know that that's just a fact. There's plenty of research showing that they do not have the same opportunities for shared decision making as women who are white. The overall negative effect of separation is that we very likely will see a delay in lactogenesis or secretory activation with the milk coming in, basically with later milk expression. There's lack of skin-to-skin, which may increase the risk of infant complications that we have seen. We have seen that skin-to-skin protects infants from these risks. So we may see more hypoglycemia, hypothermia, crying, cardiorespiratory instability, and difficulty with those initial latches. Lack of rooming in may increase the risk of infant supplementation, decrease risk of milk expression, lower prolactin levels because of not feeding as often. Lack of direct breastfeeding increases the risk of delay in secretory activation. So pumping is not going to be as stimulating as directly breastfeeding. And then again, the early bath may increase the risk of hypothermia and poor feeding. So, and then, you know, part of the problem with the COVID-19 pandemic is that our safety net is not as tightly woven in the community as it had been, and even at best, it was tenuous around the country. I think Madison would do a little better job than other places, but, you know, it's certainly not the same as it was. So leaving hospital early has increased readmissions for complications. That's something that many of us have found here, and that was one of the reasons to stop the early discharging from the hospital. Families are having a harder time finding face-to-face outpatient lactation help, so there's more video support, but not as much face-to-face. And families are also less willing to do face-to-face help. I find that my families are less likely to come in to see me in lactation clinic and want more video visits, which actually limits what we can do for breastfeeding support. On the other hand, we know that weight gain is the very, very best way to assess feeding. Poops and pees only tell you about hydration. They do not tell you that the baby is gaining well. So we do need to get some good weight checks. And then there are the issues of like affording scales. Can they get a scale? Some scales have been back ordered for home scales. And then we're not seeing as many home visits from public health support groups. Several WIC offices around the country have been closed, or they've been trying to do video visits, and I think those are gradually ramping up. But the support from other community organizations has really suffered as well. So what I recommend in my lecture today is optimizing breastfeeding support postpartum before discharge. So trying to be a little bit better, a little bit more cognizant of ways that we can give anticipatory guidance and help to prevent problems. So first, I would say to provide as much hands-on help, like making sure that there's at least a couple shifts that moms and babies are being observed throughout the entire feeding so that moms are learning what does it mean to latch, what does a good latch look like, how does she tell the difference between swallows that are nutritive, of course, because they're swallowing, versus sucks that are non-nutritive without those swallows, and when to take the baby off and switch the baby to the other side. And these are things that our nurses at the hospital are trained in through their baby-friendly training. We want them to be able to spend more time with families to educate families about this information. Educational resources for going home. If you look in my smart phrases, you'll find .lact breastfeeding resources, and there's lots of great resources in there that you can just put in your after visit summary and share with families. Prevent excessive weight loss. This is so important. So we want, and this is the reason why the early discharging led to readmissions, is largely because of dehydration, excessive weight loss. So first we want to teach hand expression to all families. So if babies are not nursing well early, moms have their hands. They can just hand express that colostrum, which is really hard to get out with pumping, in order to give small amounts of that colostrum, whatever they can express, to the baby that's really not nursing well on the first day, and we'll talk a little bit more about that. If you see an anterior frenulum, clip it. The anterior frenulum, in fact, the American Academy of Otolaryngology and Head and Neck Cancers recently put out their consensus statement on frenula, on clipping the frenulum on tongue ties. And it was a very good statement, I felt, but they did advocate for clipping the anterior frenulum. If you see it and mom's having any soreness whatsoever, really it's not going to be a problem to clip that anterior frenulum unless the parents decide not to do that and mom has no pain whatsoever. Avoid nipple shields, and we'll talk more about that, and then ensure access to breast pumps. Make sure that they know where they can get a pump, how they can get it. And then avoid routine formula supplementation if you can. Really try to optimize mom expressing her own milk to give her own, to supplement with her own milk. And then we're going to talk about moms who are at risk for a delay in lactation and a low milk supply. And if they are on that high risk, if they're in that high risk category, definitely see them back in 1 day, not 2 days, because a lot can happen in 2 days. And then consider scheduling an appointment in the breastfeeding medicine clinic at the time of discharge, either with me or with Dr. Amy Bauman, who's at Yahara, Dr. Michelle Malloy, who's at Odana. We do have availability in our breastfeeding medicine clinic. So a simple message to families, just remember, sometimes families will look at you with deer in the headlights, not knowing like what they're supposed to do. Breastfeeding seems really complicated, and many families have not gotten prenatal breastfeeding education because of the COVID-19 pandemic. So simple, empty your breasts and feed the baby. If that's all they can do, whether they're using a pump and they're feeding the baby, those are the two things to simplify breastfeeding. Empty the breast, feed the baby. It doesn't have to be that complicated. It's really when you're putting the baby to the breast that is what causes the complication, because we're trying to figure out, is the supply low? Is the baby not transferring? Why is that not happening? Why is there pain? That's when we get into problems with breastfeeding. So if you're dealing with a messy situation, go back to your basics. Let's empty the breast, let's feed the baby, and let's kind of just chill for 24 to 48 hours. Let's get that done, and then let's move on from there. And you're not going to destroy breastfeeding if mom takes a bottle, if the baby takes a bottle. Don't worry about it. The breastfeeding medicine specialists, the three of us, we know how to get a baby back to the breast when the baby has been bottle feeding. So let's say that a baby is not feeding well at the time of discharge. Then have mom practice breastfeeding just a couple of times a day. So it really is like banging her head against the wall in a way. If she's told, well, just keep nursing at every feeding and then pump after that and bottle feeding. So that's what we call triple feeding, but it's also termed triple work. And that can be unfair, particularly if a mom is going home, she doesn't have help, she has the other kids at home. It can be a nightmare for her. So then if things are not going well, practice nursing a couple times a day and otherwise pump and bottle feed the other feedings and pace the bottles, which I have a good video I can show you, but I don't have time to do that, I don't think. And so just be mindful of pacing, which I'll show you a picture of that. And then avoid finger feeding or syringe feeding after the first week, because by 1 week, your average term baby is going to be up to 60, maybe even 90 ml, and that's a lot to finger feed. So finger feeding is fine for the first couple of days, but I would encourage you not to encourage families to keep doing that because it's a lot of work, and there's no real practical evidence that finger feeding preserves breastfeeding more than bottle feeding does. Once the infant is nursing well a few times a day, then increase the number of feeds at the breast. And then really, someone needs to see the baby in the office for pre and post feed weight to measure breastfeeding effectiveness. And then that will give us an idea of whether or not mom should be increasing feeds at the breast. And of course, we want to monitor the weights closely over time to make sure that the baby is transferring well. Oh, I think there's an echo there. Okay, they're gone, good. And then remind parents that not everyone crawls at 9 months or walks at a year, but they're going to. And not everyone is a great breastfeeder at birth, but they can be. And so if a baby's not nursing well in the first week or two, it's okay. I mean, they didn't crawl at 9 months. They're going to crawl. They didn't ride their bike. They didn't ride a bike without training wheels at 4.5. They will at 6. They will at 8. They will. And so it's a matter of really believing in the baby and that you're not missing a chance. The baby's not failed and will never go to the breast if they're not nursing in the first couple of weeks. When babies are separated from moms at birth and the babies are bottle fed and mom is pumping, again, we recommend pacing all feeds. And what I mean by pacing is keeping that bottle horizontal. So when you have a bottle full of milk and you dump it upside down, I'm going to take my hand away there, you actually are putting the weight of the milk in that bottle forms hydrostatic pressure, and that makes that milk flow really quickly. So by keeping it horizontal, the baby then is taking, much like drinking from a trough rather than being under the garden hose. So we want babies to take the milk to be the ones who are asking for and receiving the milk, which is what happens with breastfeeding, as opposed to just passively guzzling milk. And that guzzling milk, it really makes breastfeeding harder because babies become very impatient at the breast. So we want you to pace all breastfeeds. And if you're looking for a good paced bottle feeding video to show your families, I didn't write this down in here, but go to YouTube and type in IABLE, I-A-B-L-E, paced bottle feeding, and you'll see a video that's quite good on teaching parents how to pace. We want to introduce, so the baby let's say the baby was separated from mom, the baby hasn't breastfed yet, then the best thing to do is actually to introduce the breast when the baby is in a quiet alert state. So as soon as the baby is really hungry and agitated, that's not a good time to be working on driving up one's instincts, because at that point, that baby is anticipating a firm silicone nipple in the mouth and is not going to be happy going to the breast necessarily. So we want mom to put the baby skin to skin, and when you hold a baby skin to skin, the baby will bob and peck, and sometimes you feel like the baby's going to jump out of your arms. I'm sure you've all felt that. That's the feeding reflex, the baby's skin to skin looking for the breast, and when the baby's jumping, the baby's actually looking for the breast. The baby will root down to the breast and then do like the kind of thing and then latch. And so being skin to skin and moving down is that repertoire, like running towards a hurdle and then jumping over the hurdle. That's the repertoire that's needed to get that baby to the breast. But we want the baby to do when the baby's in that quiet alert, not excessively hungry, just mellow state. And once that baby does that a couple times, the baby will be like, oh yeah, I know how to do that. Just like you know, the kid rides that bike without the training wheels and is like, I got it. And so it just takes those few times of doing that. And just letting parents know they don't need to do it 10 times a day. They can do it once a day, every other day, but finding the right state of mind and getting that baby to drive up that instinct at that, when the baby's in that state of mind, is all it takes to do that. And again, letting parents know that they should believe in their baby. I don't recommend putting on a nipple shield. I think nipple shields are problematic in many ways. We want the baby to learn to nurse at the breast and not looking for silicone at the breast. The other thing is that for those of you who have heard me lecture, you understand that prolactin is that's the name of the game, is part of it, breast emptying, but also keeping prolactin up. Breastfeeding is like playing volleyball. Keep the prolactin up as high as possible 24/7. So prolactin is only increased with nipple stimulation. There's no other way to drive up prolactin. If you put a cap on it, the nipple doesn't even feel the baby. So it doesn't. So I do worry about dropping that prolactin level over time, and then you're taking the baby further from the breast. So if breastfeeding is like squeezing the bulb part of a bulb syringe, if they're on the nozzle all the time, nothing's going to come out. They have to get to the bulb. If you put a cap on it, they can't get to the bulb. Does that make sense? So it just ends up being one more messy situation. So try to avoid, if your family does go home with a nipple shield because someone else had recommended one, follow the infant's weights really closely, and mom is going to need to protect her milk supply with periodic pumping after nursing in order to keep up her prolactin level and to fully pump. And then gradually work on reducing that nipple shield use. So take the baby off mid-feed, like maybe the baby can start nursing with the nipple shield, and then take the baby off mid-feed, take away the shield, put the baby back on, the old bait and switch routine, and that can work fairly well. And then intermittently trying to latch without it when the baby's in that quiet alert, sort of just waking up from a nap, kind of starting to show a few early feeding cues. And then reduce the milk supply if needed once in a while. They're using a nipple shield because mom has a super high supply, which was beyond what our conversation is today. And then I know I'm probably running out of time. I have a few more minutes. I just want you to be aware that there are some mothers who have a risk not only of a delay in lactation, which means that it may take a while for the milk to come in, but also there are other mothers who have a risk factor for low supply. So women who have a risk of delay in lactation are those who are prime-nips. So 33% of prime-nips will have a delay in lactation, meaning that their milk comes in at a time at which the babies need to have a higher volume before that milk comes in. So that's basically what we mean by delay. So the babies are going to need some supplementation before mom's milk completely comes in. Having a cesarean birth, a long duration of labor, elevated cortisol levels, so moms who are stressed, a high BMI, and gestational diabetes. And the moms at risk for low supply, meaning that they're going to have difficulty establishing sufficiency for their babies, would be those with a breast reduction. You have to assume that women with a breast reduction are not going to make enough milk. So definitely they need to start out supplement, with the idea that they need to supplement. If a breast has been irradiated because of breast cancer, they will not make any milk. The glandular tissue is gone. That's the whole goal. Little or no breast change during pregnancy can indicate that she may have mammary hypoplasia and not sufficient glandular development. Women who have a high androgen state, such as PCOS, those who are insulin resistant, those with a history of infertility, advanced maternal age in women's 40s. Women in the 40s actually start to have some loss of glandular tissue at that point. Medications given intrapartum, like decongestants, hydrosteroids, epinephrine, diphenhydramine, can reduce milk supply. And then women who've had a history of prolactinomas, you think, oh, you had a prolactinoma, you should make a ton of milk. But if they were treated with cabergoline or bromocriptine, they may have burnt out those prolactin cells. And many women have difficulty establishing sufficiency in that situation. And then women who smoke generally make insufficient amounts of milk. And then I want you to be aware of the 37 and 1/7 weeks. These are the scariest babies because they, especially if they leave at 24 hours, they are not mature. Yet they fall out of that protocol of the 35 to 37 weeker. But we know now that there's the late preterm and then there's the early term. So the Academy of Breastfeeding Medicine now has in their protocol that they updated in 2016 on feeding the late preterm issues regarding the early term, because we know a 37 weeker doesn't nurse as well as a 38 weeker, who doesn't nurse as well as a 39 weeker. And so these babies are really at high risk for poor feeding, jaundice, hypothermia, dehydration. And many of us feel that a 37 weeker should probably be lumped in that 34 to 37 week, like that category of 35 to 37 weeks should be 35 to 38 weeks really, because these babies do have very similar feeding issues as those who are 36 and 6, I should say. They do seem to have the highest rate of readmission at this point, and so these babies definitely need to be seen within 24 hours. And it wouldn't hurt if these babies are sleepy to have mom pump afterwards and bottle feed or syringe feed or whatever, some expressed colostrum or breast milk. I want to mention that the Human Milk Banking Association North America does, we know that the donor milk that we're using at the hospitals are safe, that their processes have always been safe against infectious diseases, and so you don't need to worry about donor milk. I'm going to skip this part about going home because unless you have any questions, if people have any questions about going home, but just to say that there are some different recommendations between the Center for Disease Control and the World Health Organization. The World Health Organization does state that if moms have symptoms of COVID-19 when they're going home, that even if they don't even have a mask, just keep breastfeeding no matter what. CDC advises trying to still isolate from the baby for that 14 days if they were positive, and the typical 72 hours without symptoms and at least 10 days after being positive. The American Academy of Pediatrics also states that a caregiver who's going to be taking care of the baby be under 60 years of age because of the risk of illness. And then again, direct breastfeeding is discouraged. But I just want to say that as a reality check, I think we have to meet parents and families where they are, because when you think about it, mothers can be isolated in a room, right? And then the baby is being taken care of by someone else who is clearly going to be at risk for COVID-19 because that caregiver is in the same household as someone who's positive, and then you may have other kids at home who are the total vectors. They're not going to ignore their mother who's just in the hospital by letting their mother be in a room and never entering that door. That's crazy making. Of course they're going to enter the door. You try to keep a 2-year-old out from their mother when they come back from the hospital, they'll kick down the door. And so these 2-year-olds are going to be between the mother who's COVID positive, and they're going to be between the newborn and the other caregiver. And I just don't even see in reality how we can prevent that infant from being exposed to COVID-19. So my advice is, I definitely want to talk to families, see where they're at, but definitely support their decision to directly breastfeed. And then to recognize that we are seeing more postpartum depression. This was, I think, from the Washington Post, an article, series, a woman who was collecting pandemic postpartum stories, and that we are seeing, again, more postpartum depression for many reasons, which I won't go into, and there are some good resources for postpartum depression. And one service I wanted you to be aware of here in Wisconsin, we have the Periscope Project, which is a phone number that you can call if you have a mother with postpartum depression who has complicated care, particularly if it has to do with breastfeeding. They are great. They have a national grant to support families around the country, mainly by having health professionals call and having access to talking to a psychiatrist who specializes in postpartum mood disorders. All right. So in conclusion, breastfeeding optimizes the health of infant and mother. Breast milk components theoretically may help to decrease morbidity and mortality among infants with COVID-19. We're hoping to see some data on that. And postpartum hospital practices are shown to enable successful breastfeeding, but these have been disrupted. So we want to have strategies to anticipate and optimize care for families when they leave the hospital. Infants who are bottle fed during maternal infant separation have not lost their ability to breastfeed. They can do it. We trust them. They can do it. And families are receiving very different care. We need to recognize that. And close post-discharge follow-up is really critical. See them the next day, please. And I'm happy to take any questions. Thanks a lot for listening to me.